Good evening, everyone. Thank you for joining us this evening. Before we get started, I'd first like to thank Cindy Thompson of Alternative Communication Services, ACS, for providing captions this evening. Hope everybody has their caption pod open and ready to go. If not, let me know and I'll type to you how to get captions. Control F8 on your keyboard will get you there quickly, or the CC button on the top of the video screen. We are very honored to have Dr. Christine Cassel with us this evening. She's the President and Chief Executive Officer of the National Quality Forum, and she's one of 20 scientists chosen by President Obama to serve on the President's Council of Advisors on Science and Technology, otherwise known as PCAST. And she's the co-chair and position leader of the PCAST report to the President on the future directions of health information technology. Thank you, Dr. Cassel, very much for presenting this evening. We very much appreciate it. I'll let you get started. I just want to remind people that if they have questions for Dr. Cassel, please post them down in the chat box on the lower left of your screen. When Dr. Cassel is finished running through her slides, I'll go ahead and voice those questions to Dr. Cassel so that she can answer them, and everything is part of the CART transcript. Thank you again, Dr. Cassel. Welcome, and I'll let you start.
You're welcome, Nancy. It's a pleasure to be here. Can you hear me okay?
Yes, I can.
Great, great. Well, it's a pleasure to join this group. I really appreciate the opportunity to do that. And what I will do this evening is to just go through a sort of a high-level summary of the PCAST report, and then welcome questions from any of the participants that might expand on some of the issues and some of the areas involved. So first, let me just say that this report is part of a larger piece of work that is still ongoing regarding aging and technology. And this was actually a personal interest of the President in looking ahead, as the good news is our society is living longer, and with that come often challenges of some disabilities and some impairments that lead to people having less ability to live independently, be productive, and enjoy quality of life in their later years. So his question to PCAST was, how can technology help mitigate these challenges and help people be more independent, be more productive, and have higher quality of life as all of us hopefully can live into our later years. So that the context started with the report on aging. That report we anticipate will come out in sometime late winter, January or February is what we hope. And it will include a range of issues related to mobility, cognitive impairment, social engagement and connectedness, many things where there are cross-cutting themes. But we thought, and the President agreed, that the hearing issue was so central to all of this and so important that he asked for us to package that report up separately and deliver it sooner. So that's what you're seeing in front of you tonight. So the scope of this hearing study is that, as I just mentioned, it's part of the broader examination of aging and technology. And we recognize that this issue is sort of risen finally, in my opinion, to the level of attention with the Institute of Medicine report and the PCAST report that it deserves. I should let the audience know that I'm a physician. I'm an internist in geriatrician, so I've spent my career working on issues of aging and understanding ways to improve lives for all of us as we get older, and clearly hearing is one of them. So that's kind of my particular focus on this. We do understand that hearing loss is a very diverse set of issues and conditions, that there are somewhat different and importantly different issues for children, for many adults who have unusual causes of hearing loss or very severe hearing loss, and those with the kind of red flag conditions that the FDA outlines are explicitly outside the scope of this study. So this sort of fast track of this study was to say, what's the low-hanging fruit? What are the things that could happen more quickly that would really help this large and growing number of people who have age-related, mild to moderate hearing loss? This is a list of the participants in the PCAST report. Some of them, as you notice with the asterisks, are PCAST members, and some of them are subject matter experts that we brought in to work on the report. And I want to particularly acknowledge this remarkable staff, especially Ashley Predith, who worked with us on this, and Rob Saunders, who's with me here this evening. Let me just stop here and say a word about PCAST for those of you who aren't familiar with it. This has been a real privilege for me to serve President Obama and this administration in this way. PCAST has been in existence for many decades, since World War II, and presidents use their PCAST advisors in different ways, but it is set up to be independent scientists who advise the president. So we don't advise Congress, we don't even really advise agencies of the government. We advise the White House about questions they ask related to a very broad range of science and technology. So everything from energy science, the recent climate agreement, to nuclear weapons, to computer science, to geological science, to astrophysics, cybersecurity, just, anything that relates to science and technology. Clearly, healthcare and biomedical science is a part of that. And so that's kind of the scope of this. So many of the scientists you see listed on this screen are people with really amazing expertise and experience in computer science, in various aspects of technology and that high reliability manufacturing and engineering. So it is a really rich group of experts to draw on for this work. So the first thing is the context, and I don't have to tell you folks about this, but it's very important that the report is framed in terms of this really urgent social problem, that roughly 30 million people have some significant hearing loss now. And in the older population, hearing loss has now been demonstrated to be associated with social isolation, inability to get around safely, dementia, falls, depression, inability to work. A lot of older people need to keep working now as they get older, and it's actually better for them as well as for our economy if they do so. But if you have trouble hearing, it makes it very difficult to be engaged in your community as a volunteer or paid worker in any way. And that just becomes more and more important as people are living longer in our society. And the number of people with hearing loss rises exponentially with age. So nearly half of people over age 60, 80% of people over age 80 have some degree of hearing loss. And that number, that 30 million, is a very rough number. It's hard to know the denominator because of something I mentioned in a minute, which is that people often are reluctant to admit it or to seek help. And that's an important thing to deal with. And so you can see at the bottom of this slide, few adults actually use hearing aids, somewhere between 15 or 30%. Hard to know exactly what that number is because we don't know the denominator really. But there are a large number of people who either do not seek help with hearing, or when they do, they don't really get the help they need, and so they end up not having hearing aids. What are the reasons for this? Well, the major reason that we found, and we did a lot of research and talked to a lot of people and organizations, is the high cost. And many people say this, combined with the fact that most people pay out of pocket, that Medicare doesn't cover it, and that most insurers don't cover it. And so a little commentary from me as a geriatrician is that for some reason over the years, insurers have not thought of this as a health issue. And when you look at that data about the association with all kinds of health risks, it's really amazing to me that insurance companies and that Medicare doesn't cover it. But one of the things that's an impediment to that is this high price. So it becomes a vicious circle that the government looks at, you know, what it would cost for Medicare to cover hearing aids for millions of people at these price tags. This is, you know, $2,400 average per hearing aid. Most people need two, so you're talking $5,000, $6,000 per person. That's a budget buster for the federal government. So that's been a real impediment. And then the other thing is that in most modern electronic technology, innovation reduces the cost of the products. We see that with our iPhones. We see that with other auditory technology like music and television and things like that. But in hearing aid, hearing technology, there's been innovation, but it hasn't driven the cost down the way it has in other aspects of technology. Another set of problems include these, and you folks could probably come up with others as well, but it's really difficult. So you have a consumer market, particularly since there's no insurance coverage, and it's very difficult for consumers to shop for the best value. You know, when you get a prescription for medication, you can actually go to different drugstores and see there are actually different prices that different drugstores charge for a medication. Or an analogy we make in our report with eyeglasses, you get your prescription for your eyeglasses and then you can go to any one of a number of vendors to pick the eyeglasses that you like how they look, or they work better, or they're less expensive. You can do it online. So that kind of freedom of the marketplace really doesn't exist for people shopping for hearing aids. And for all kinds of reasons, the practice of bundling where the audiologist services are connected to a specific company or one or two companies and it's all one price, complex state regulations of who can excuse me, who can provide hearing aids, and also we feel unnecessary restrictions on internet availability. And then of course there's the social stigma, and my personal view is that that in a way is in part because of the lack of adoption. If more people used hearing aids, it would be less of a social stigma. Same as with eyeglasses, you know, that now it's kind of fashionable to wear eyeglasses, and that I believe that it's such a common phenomenon that people need help with hearing that we really need to overcome this social stigma. And then finally, the lack of engagement by health providers. It's not just that insurance doesn't pay for it, but you know, it's not, most primary care physicians don't ever even ask you if you're hard of hearing as part of their screening exam or office visit. Geriatricians will do this, but they're few and far between, and so we haven't really included it in part of our healthcare system, if you want to think about it that way. So that's the context in which PCAST did our work, and we concluded that the problem is ripe for change, that it's really kind of at a tipping point right now, for a couple of reasons. One is that there are rapid advances in new technology, both within the traditional hearing aid industry, but also within the PSAP sector, where there's a lot of innovation going on. And as we looked at the federal regulations, mostly FDA, but to some degree the Federal Trade Commission as well, it seemed to us that a few, just 3 or 4 changes in federal regulations could give great momentum to needed changes in this area. And so here's a couple of our conclusions, looking in particular at the FDA, and I'm going to talk about those recommendations in just a minute. A lot of the concern with the FDA current regulations is that, well, there could be lots of insidious and dangerous red flag conditions that cause hearing loss, not just age-related, progressive, bilateral, mild to moderate hearing loss. And so you don't want people just getting amplification devices or devices for their hearing if they haven't had a medical checkup to see, do you have an acoustic neuroma, or, which could be a bad thing, do you have wax in your ears, which is pretty easy to detect and fix, or some other condition that causes unilateral or painful hearing loss or other kinds of conditions. But, you know, if you think about it, the risk of millions and millions of people going without help for their hearing and the kind of medical conditions that I mentioned earlier associated with that, compared with the relatively rare incidence of conditions like acoustic neuroma, part of what the FDA is charged to do is to weigh the risks and benefits in any given treatment. And we felt that here's a place where the benefits of opening up the market for hearing aids really outweigh the risks of a few serious conditions, especially if there were clear warning signs that said, if you have any of these conditions, then you should seek medical help. So that was one very strong conclusion of the report. The other is that now is really an opportunity to increase access to less expensive technology. And in particular, because we're anticipating a report from the Institute of Medicine, I'm very glad they're doing a much broader, more comprehensive report that will look at all kinds of different sources of hearing and look at the hearing health environment, etc. And so we felt like this could give some momentum to that study, but didn't need to wait for that study to come out. So our recommendations are towards these 3 goals: to reduce costs to consumers, to increase the number of people who use hearing technology, and to stimulate innovation and technology development. So now you get the small print. So this is our first recommendation. It has 2 parts. Now this is basically taking an analogy with eyeglasses and visual impairment, that, as you know, for people who have common, often age-related presbyopia, we call it, inability to read at a close distance, you can go into any drugstore or online and buy readers, and you can try out the different strength and see what works for you. And so we do understand that hearing loss is somewhat more complex than that kind of visual impairment, but we still think that there is an important analogy here. So I want to be clear that we're not saying it's exactly the same thing, but that we envision a world where a range of hearing devices and hearing tests, and you can see that in the second part of the recommendation here, would be available online and to people in retail outlets such as drugstores. Drugstores may even decide to have hearing specialists on site if it turns out that there's a big enough market for, again, not the more serious hearing loss, but for the range that we describe as mild to moderate. And oh, by the way, I want to also mention that some of the correspondence that I've received since this report came out points out that it isn't just older people who have this problem or who could make use of this more open market in hearing aids. And so that's definitely true. I think if what we described were to happen, you know, the market would be available for people of any age to access. So the first recommendation is that FDA should designate a distinct category of basic hearing aids for this non-surgical air conduction hearing aids intended to address bilateral graduate onset, mild to moderate, and I'll just say hearing loss because it doesn't have to be age-related, and adopt distinct rules for devices like this because, as you know, it wouldn't be without regulation. FDA does regulate over-the-counter devices. And that they should approve these kinds of devices that meet these requirements for over-the-counter sale, as well as for diagnostic hearing tests that would help people identify what kind of device might work better for you and try out the different devices. The second recommendation is that FDA should withdraw the draft guidance of November 7, 2013, which is about PCAST. Many of you may be familiar with this, but it really goes even much farther than their guidance from 2009. And it even sort of says PCAST not only can't advertise themselves as helpful if you have hearing loss, they can't even advertise themselves as helpful if you have normal hearing and you have trouble hearing a conversation in a noisy restaurant, which is actually most of us, right? So it puts a lot of, we felt, unnecessary constraints on how the PCAST market, which is very innovative, could get its message out to consumers who could use it. So as you can see here, we argue that PCAST manufacturers should be able to make whatever truthful claims, as long as they're truthful, about how their devices might be useful, and should not exclude people who might have mild to moderate hearing loss from being talked about in that marketing and labeling. So recommendation 3 and 4 are for the Federal Trade Commission, because this was about 20, little more years ago, when actually the optometrists had the same kind of very close relationship with having to prescribe glasses. And the FTC got involved in this and opened this market up with a couple of simple regulations. One is called the eyeglass rule, which basically requires the expert, in this case the audiologist and hearing aid dispensers who perform standard diagnostic tests, and this is important, those tests would have to be made more standardized, to provide the customer with a copy of the relevant audiogram or audio profile at no extra cost and in a form that can be used by other dispensers, so not locked into some formula that only applies to one company, and certainly not conditioned on any agreement that you have to buy it in any particular place. And then recommendation number 4 is actually analogous to a subsequent contact lens rule, where FTC defined a process where patients could authorize, in that case, their optometrist or ophthalmologist to give a copy of their test results to somebody in another state or in another organization. So this would be the same thing. The hearing aid vendors would be able to obtain a copy of test results from another hearing specialist if authorized by the patient, and at no additional cost. So we comment here that FTC does have the authority to just initiate change in regulations like this, but they very rarely do so. They have a lot on their plate, and it just doesn't rise to the top of their list unless Congress asks them to. So here's another place where your organization and other advocates, if you think this is a good idea, could be helpful in going to your representatives and maybe through congressional request asking FTC to move on this. It would not be a complicated thing for FTC to do. So in summary, and this is I think my last slide here, that untreated hearing loss is a major public health and social problem linked with many conditions and also just with the vitality of our society, and that for a whole range of reasons consumers have difficulty accessing hearing technology because of cost, limited ability to shop, at the same time that we're in the middle of a technology revolution in consumer electronics, and we're not able to take advantage of that. So PCAST found that a few key changes in federal regulations could really accelerate needed improvements and not put public health at risk. So let me just, I think that's the end. So Nancy, let me turn this back over to you. And I've been noticing out of the corner of my eye there's some questions
right
there, so I'll let you moderate that.
Great. Thank you very much. It's a very informative presentation. The first question tonight comes from a former board member of HLAA, Deb Baker, and she has said or asked, has there ever been any investigation of price fixing or antitrust activity in regards to hearing aid pricing?
We didn't find any evidence of any investigation into that, but in this country, I think there are some lessons in other countries, but it certainly is the case that if the Federal Trade Commission were to get involved in this market, they would be looking at that. That's a really major focus of their activity on behalf of the American people and the American markets. And it would certainly encourage competition, if nothing else.
Okay. Abram asks, Dr. Cassel, I thought the law already required access to one's audiogram, and from my understanding, most audiograms are relatively standard measurements.
That's interesting. I'm not sure the law, I mean, I think probably the patient's rights, the patient's Bill of Rights requires that patients have access to all their records, right? So this is kind of a general thing. But we know that that law is very hard to actually implement, that even if you're talking about medical records, it's very hard for people, particularly in electronic records, to get those records. So that's going to be a changing landscape, and we're going to need more and more consumers to demand their rights here for people to actually do that. What we heard over and over again from people was that they were not able to do that, or they didn't think they could, so therefore they didn't pursue it. Sometimes you can make it such a hassle that people just won't bother. So what we're urging here is that it really become a norm. The second part about are these standardized or not, I'm not an audiologist, but we did talk to a lot of audiologists in our work, and several of the people who are concerned about these regulations say, well, it's much more complex, and then it depends on what the device is, that it has a somewhat different profile or different signature, and there are all these other different variabilities. Like I say, this is not my area of expertise, but enough highly credible academic audiologists said to us this could be more standardized. It isn't scientifically impossible to standardize it. It's just that people haven't done that. So that may be, part of the issue. In computer science, we call it interoperability, where, one kind of technology should be able to talk to another kind of technology, and you should be able to describe them both in electronic terms in the same way.
Okay. Ron Levitt commented that the price of PSAPs and hearing aids are about the same when purchased in bulk as does the VA, quoting Dr. Lou Beck in 2015.
So in the VA, the prices are the same. Is that what he's saying? Yeah. Well, you know, we found that too. We talked to people in the VA, and we looked at some of the markets internationally too. And these same 6 companies that are kind of the big 6, as they call them, sell the very same devices to the VA for, you know, somewhere between $200 and $400. I mean, they wouldn't give us an exact figure, but you know, the VA has first dollar coverage for every eligible veteran to get hearing aids, and the same thing happens in many countries. The National Health Service in England does the same thing. They offer the same kind of hearing aids, and you can be pretty sure that given, you know, how careful the National Health Service is about what they spend, that they are not spending $5,000 per person on hearing aids. And so they're getting a better deal from the same companies. So that's why we think that opening up competition would really help to make the prices more affordable all around. And so we're not saying necessarily that PSAPs are better. I mean, I actually think people may actually find the traditional hearing aids are better for them, but they shouldn't have to pay 10 times as much to get that.
Okay. Anna Gilmore Hall says, what happens now that the report has been issued? What should consumers who support these recommendations do now?
Well, I made one recommendation about talking to your elected representatives regarding the FTC, or even regarding the FDA. I mean, because I think, you know, that is part of what congressmen and senators respond to, is people who are their own constituents. And this is such a common issue. Every year, there's at least one piece of legislation introduced from somebody who either themselves is doing it because of their family, or they've heard from their constituents. And so far, you know, most of those are oriented towards getting Medicare to pay for it. And then as soon as it gets looked at by the OMB, or the Congressional Budget Office, then the cost is just too high because they go by the current price. And so that's why we feel that, you know, if the Federal Trade Commission and the FDA were to make a couple of these changes, it would drive the price down, and then it would be much, much more likely that we would ultimately be successful in getting it included in private insurance and in Medicare. So the other thing is, and again, you know, with great humility, my father was very hard of hearing throughout most of his adult life, and so I'm very sympathetic to all of the challenges that people face. But I think, you know, the advocacy of trying to work with communities to overcome the stigma, that's, I'm sure, going to be a big part of the IOM report. And I think that all of us somehow, in many different sectors, in intergenerational contexts and educational contexts, can figure out ways, and Nancy, your member is probably much better than me to say, what are things that all of us could be doing that would help really overcome that?
That's true. That's true. I think a lot of our members are very savvy when it comes to technology, and they are very willing to advocate for themselves. So I think more people can take a lesson from our members, because they're very effective when advocating for themselves. Jan Bluestein, a new HLAA board member, says the PCAST report is exciting for us. It feels like a window of policy opportunity has opened, so thank you. How best can we send a message to the FDA? Is there a message that you think would be particularly effective coming from advocates? Who exactly should we contact at the FDA, for example?
Well, you know, I actually don't have an answer, I mean, of an email address I can give you, but I think we could actually look into that and get back to you, Nancy, and you could, you know, convey that information to your members. But I do know that a lot of FDA changes go out for public comment when they're issuing a new guidance or something like that. So, you know, there is a new commissioner at the FDA. He hasn't been confirmed yet, but he's a really terrific scientist, cardiologist from Duke, Rob Califf, and I think it's very hopeful that he will be confirmed. And, you know, he's looking at this issue with fresh eyes. So keep your eyes open, and when FDA does decide to move on it, definitely you want to get people commenting, because, you know, there will be many comments on various sides of this issue, I'm sure. But in the meantime, I do think working with elected representatives and perhaps with other organizations that you might be a part of.
Okay. Okay, we'll stay tuned, I guess, for more information and get that out to our members. Okay, Nancy Kingsley would like to, has said the dispensing organizations are opposing the PCAST recommendations. How will their objections be addressed?
Who is? I'm sorry, I didn't hear you.
The dispensing organizations are opposing the PCAST
organizations.
Recommendations.
Well, you know, it's very interesting. I haven't been counting, but I would say probably 80% of the responses we've received have been very positive, including a number from audiologists. Now, some of the opposition has also come from the audiology community and from the industry, the major companies. But, you know, even what they say is mostly worry about these undetected medical conditions. And, you know, FDA themselves will tell you that they require a medical exam and that the vast majority of people waive it. So if you do the numbers, you say only, let's be generous, let's say 30% of people with hearing loss get hearing aids. You know, it could be much less, but let's say 30%. And then 80% of those waive the medical exam. So the vast majority of people who might have these undetected medical conditions aren't going to get seen at all. And so the current regulation just isn't solving that problem. I actually think, as a physician, that if you had more people coming into the hearing system and you had clinics and drugstores and primary care offices and people would look in, you know, a nurse practitioner would look in your ear and see if you have wax, you would actually, and ask you a few screening questions, you would probably detect more of these so-called red flag conditions than we currently are doing now. And that seems to be the major thing that the audiology community is putting forward.
Okay, Ken Kluski says, wonderful presentation, thank you. I'm wondering if the report will cover hearing aid connectivity to assistive listening devices. Getting the industry to adopt an open Bluetooth standard encourages companies to create innovative assistive listening devices that could directly connect to hearing aids.
Absolutely. You know, not just Bluetooth, but we think that that's why I'm saying kind of at this moment in time where we see technologies of all sorts, consumer technologies, but particularly acoustic electronics and that whole world is just exploding and exponentially. So there really ought to be a much more vibrant market in these kind of devices, and we ought to see a lot more improvement in them. You know, the way it works with other kinds of consumer electronics is that if the device doesn't work, then it, you know, consumers don't buy it. And so the manufacturers are really motivated by the marketplace to produce something that's very user-friendly and that really works for people. And, in this day and age of consumers talking to each other on the internet, it gets out pretty quickly if something is a bad product. So, so I think both driving out the products that don't work and really stimulating innovation in Bluetooth interoperability and other kinds of auditory environmental alterations that might work better for certain kinds of settings, or certain kinds of rooms, and that they all ought to be interoperable, so that if you have a hearing device, you can just set it in anybody else's loop environment, for example, or in a theater or whatever. That's kind of my ideal of where we ought to be headed.
Ron Levitt commented, he said, "We did a study that showed that patients are very poor judges of their degree of hearing loss. So how can the patient know if they are in the mild to moderate category as noted?"
Well, that's a good question. Again, reminding you that I'm not an audiologist, but we have heard from a number of experts in the field that's what you could find out from an online hearing test, or from a hearing test at your local drugstore. It could tell you, no, we actually recommend that you go to an audiologist and not, buy this device here. Or you might try this device and see if it works. If it doesn't work for you, there should be a mandatory. Most of these things have, 60-day or 90-day return policies. And then you go to the audiologist. But you have a chance to try something out first and just see if it works. But there are ways of developing online and retail hearing assessments. And it's another area where if it were more common and more people did it, then the technology would develop and it would get better too.
Right. Georgia says, I serve on the Rhode Island Commission for the Deaf and Hard of Hearing. How can we and our sister state commissions advocate for these findings with the PCAST?
I guess, there's a lot of questions from your members about how to advocate, and so I don't want to repeat that too much. I mean, I think that people really should be empowered to advocate in every way you can. So some is with your federal government, some is with elected representatives, and some is probably even with the providers themselves. And let me just say something a little bit chancy here, but you'll understand what I'm saying. Because I've been talking with friends of mine as I've been working on this report, and hearing loss is very common. So everybody knows somebody or has somebody in their family who suffers from this problem. And a couple of people, once I shared with them what we were learning, then they went to the audiologist and they said, well, does this really have to cost so much? And I have this information, and they started actually negotiating with them and drove the cost way, way down in several of the cases, and actually opened up a conversation with the audiologist. Because, like anyone else, audiologists are scientists as well as business people, and many of them are kind of maybe locked into this current business model, but many of them are not, and they understand. I mean, it's kind of interesting. We've gotten letters from people in the field who kind of said, we're really glad that you've raised these issues and we all need to be talking about it more. So I think that this sort of may be a tipping point for a more open discussion, particularly in the hearing loss community.
Mm-hmm. Dave Myers has said, thank you for the excellent presentation, Dr. Cassel. Question. Did you discuss the implications of the 4 recommendations for the viability and future of the audiology profession? I'm not an audiologist. I'm just wondering about the future business model for the profession that serves me.
Well, I think there are going to be implications for the current business model, because we think the current business model is outmoded and not supportive of a competitive environment. So there will be winners and losers in this. I think the winners will be the consumers by far, by millions and millions of consumers and families who will benefit. And some people might lose some parts of their income or their market share. But I think in terms of audiologists, well-trained audiologists, there is not a shortage of need for those people. I mean, if you look at the numbers and again the aging population, that we need well-trained audiologists, and they need to be available in many more ways with a much more flexible access to multiple different ways of handling hearing loss, not just to one or two kinds of devices. It may be that the hearing aid dispensers who are licensed at the state level, who are not as highly trained as audiologists, may be the ones who lose some market share out of these recommendations. Or, you know, those people may end up going to work with the local retail providers who begin to open up this market. So you know, you could see other opportunities for people who have that expertise.
Don Bataille says, good program, thank you. Has there been any discussion requiring hearing aid manufacturers to fall in line with ADA communication accessibility requirements to provide a Tcoil in hearing aids?
Not that I know of. That's a really interesting idea. And you probably know more about ADA requirements in this regard than we do. I mean, it seems like that should certainly apply. But I'm just not aware of any.
Okay. Deb Baker has said audiologists charge thousands in service fees for hearing aids that they can purchase for hundreds of dollars. This was exposed by the state of California. How do we get the FTC to address this?
So your question, say that again. I'm having trouble hearing you through this technical.
I'm sorry. Audiologists charge thousands in service fees for hearing aids that they can purchase for just hundreds of dollars. This was exposed by the state of California. How do we get the FTC to address this?
Well, you know, I think my view is opening up the market, which the FTC could do, is the way to address that problem. Because if a consumer can go right next door and get a better deal on the same hearing aid or even a better hearing aid, then that person is not going to be able to do that anymore. And you know, the audiologists have not. I mean, this model has been in place for so long that it's kind of been an accepted idea that this is the way it's done. So they will have to adjust their business practices to support a new and more open marketplace. But I think they could easily do that. And you know, one of the things we hear is that they have to actually pay the company a much higher number. It's not just some experts told us that the parts that go into the hearing aid are just $100. But certainly, you know, somewhere within the range of $200 to $400, what we heard from the VA. So that if the audiologist has to pay the company $1,500, let's say, for that same hearing aid, then they have to charge you that much, and then they add their own services on top of that. I actually don't know. I suspect there's a whole wide range of what the business practices are there. It's not very transparent. That's another thing FTC could, you know, try to require, which I think would be very helpful. I'm a big believer in the market and allowing the market to work, but it's not going to work if it's not transparent and it's not competitive.
Okay, David Beers says, given the recently discovered negative health consequences of untreated or undertreated hearing loss, don't you think it would be wise to have studies done comparing the benefits of PSAPs compared to traditional hearing aids before moving in the direction of recommending PSAPs for persons with hearing loss?
Well, a couple of things about that. One is it would be a good idea to study all those things, and I know that Frank Lynn, for example, at Johns Hopkins is doing some pilots with NIH about a big randomized trial, really looking at the medical consequences, some of the things that I talked about before, and whether those are mitigated if you address the hearing loss. That's a kind of a hard study to construct, actually, if you think about it, but he's a very good scientist. We did not feel, we actually asked ourselves that question, should we study the comparability of the PSAP with the hearing aid before we make this recommendation? And we looked at the technology involved in both, and we talked to lots and lots of experts. First of all, much of the technology is exactly the same between the two. Some things that call themselves PSAPs or call themselves hearing aids under different circumstances. And the other is that for some people, just simple amplification, which is what the simplest PSAPs do, actually is adequate to get you through the first, couple or 3 or 4 years if you have progressive age-related hearing loss. And the other thing that's so important about that is that if you wait a number of years before you seek help for your hearing loss, then it becomes ever harder to get back to normal because your brain loses the ability to distinguish speech and other things that it's hearing. So even just something that's inexpensive and that is that works for you in most environments is a whole lot better than nothing.
Okay. Anna would like to know how you think this report will impact the IOM report.
Well, we don't have any inside information on that. As you know, the IOM has very strict rules about confidentiality, and we are as interested as any of you in what this report will say. What I can tell you is 2 things. One is that we attended every single one of their open sessions, so we heard all the same testimony that they heard. We read everything that we could get our hands on that they were reading. So, we saw a lot of the same material. The other thing is that I gave exactly the same presentation to the IOM committee. And there were lots and lots of good questions, but the tenor of the questions was very supportive. So that's all I can really say about that. And like you, I'm looking forward to their report, which I understand we are expecting in the summer.
Right. Okay. Ed Schickel would like to know, if the VA can purchase a hearing aid at less than $400, then doesn't that defeat the argument that hearing aids are too expensive for insurance, Affordable Care Act, or Medicare to cover? Good point, Ed.
Well, in my humble opinion, yes, I completely agree with you. But the way, I can't speak to what private insurers do, but the way Medicare works is that if you make a recommendation about adding a new benefit, then it has to be costed out by the Congressional Budget Office. And they do an analysis, and it's required that it be cost neutral overall. So you have to find something else to cut if you're going to do that. And every time this has been proposed, what the CBO uses as its metric for what Medicare would pay is the market price. And so you can say to them, well, if Medicare were to decide to pay for this, it would have a lot of ability to drive the cost down. I mean, I certainly imagine that would be the case. But that's not how the analysts, the economic analysts who do these studies, think about it. They think about it as what is the current market price.
Okay, Richard Einhorn said, your report focuses on mild to moderate hearing losses, many of which are not served presently by audiologists. Do you see changes in the delivery model for technology appropriate for severe to profound, or do you anticipate that people will still get powerful hearing aids only from audiologists and hearing aid dispensers?
Well, first, I am glad to hear from Richard Einhorn. I have read his articles and very much admire his work, and you should know that our committee took a lot of that into consideration. You know, you probably better than me could answer that question. We were very conscious of the fact that we didn't have the expertise and the time to go into the whole range of questions about all of the more severe causes of hearing loss and more severe manifestations. So that's why we chose to start with this mild to moderate, which is, you know, a large number of people. But as I look at innovation, technical innovation in other areas, I think that it's quite possible, perhaps even likely, that once you began to really get a vibrant market in this area, that there would be a lot of innovation for people, you know, who need cochlear implants and who need other kinds, and there would probably be new approaches actually for people who have more severe hearing loss and more complex causes.
Okay, this is a good question that comes from Dana Mulvaney. My understanding is that audiologists currently can bill insurance companies only for diagnostic services, not treatment or rehabilitation. Can you comment on whether the PCAST committee discussed this and whether there is any concerted effort to enable audiologists to bill insurance companies for providing habilitative or rehabilitative services?
A couple of points, mostly just a caveat that PCAST is the presidential advisors on science and technology, not on economics and not on insurance benefits. So, you know, we don't have, that's not our purview. Now, as a geriatrician and a person who works in the health policy field myself, I can say that it's very hard for the federal government to require certain kinds of benefits be covered by private insurance. In the exchanges now under the ACA, there are sort of minimum benefits that are required. Most of that, however, is still managed by state rather than by the federal government. So if there did start to be a trend in that direction, and if there was a lot of public support for it, that's probably where it would happen. I do know that there are some major, large private commercial insurers who are beginning to put a toe in this water. And so, you know, people are understanding what a big problem it is. And I think once we get more and more information about the medical consequences, there'll be a stronger case for that.
Okay, I think we probably have time for just one more quick question before 9 o'clock. Ed Schickel has asked, is it probable that the dB level of some PSAPs could actually damage mild to moderate hearing loss, just as the current music players do?
That's a good question, because second thing, something I expect will probably come out of the IOM report is some prediction that we're going to see more hearing loss as the younger generation ages, with people who have these tight earphones and listen to very loud sound. But you know, that's what the engineers in our group said, is that's a really easy problem. That's something the FDA could regulate in an over-the-counter product. Just say that decibels can't go above a certain level, and you know, create a safety standard. That wouldn't be hard to do.
Okay. I see lots of thank yous and definitely some more conversation that maybe we can continue in a future webinar. We would love that. And again, thank you very much. It's so informative, and we'll stay on this. And of course, any information to report about how to reach the FDA or the FTC, we'll report
Yeah.
in our e-news and other
We'll be in
communications.
touch
So
with you. We'll try to see if we can give you some useful information there.
that would be great. That would be great. Thank you again, Dr. Cassel, very much. This was
Well,
great.
and thank you and your organization for all the good work you do.
Thank you. All right,
All
take
right.
care. Happy holidays, everybody.
Good night.
Okay, good night.
Turn it off? No, I have to turn it off. So hit I, and then hit this video button and talk.